Hello everyone, welcome to my YouTube channel Easy Nursing Lectures. So today we are here again with a new topic, that is preterm labor. So we'll start with the topic. So first we will start with the definition. So how do you define preterm labor? So preterm labor is the onset of the labor. Okay, so how does normal labor occur is in regular painful uterine contractions, also associated with effacement and dilatation of the cervix. Okay, but this is happening when before 37 weeks of gestation. Before 37 weeks of gestation, counting from the first day of the last menstrual period. Okay, so 37 weeks of gestation counting from the first day of the last LMP. So this is the definition of preterm labor. Now there are some terms that we will discuss. What is preterm infant? So preterm infant is any infant who is born before 37 weeks of gestation, that is called as preterm infant. Then there is also a term called as very preterm infant. Very preterm infant क्या होता है? Infant which is born before 32 weeks of gestation. Before 32 weeks of gestation is very preterm. Preterm is before 37, and moderately preterm infant is infant who is born between 32 to 34 weeks of gestation. That is called as the moderately preterm infant. Then again late preterm infant. Late preterm क्या होता है? The infant which is born between 34 to 36 weeks of gestation. Okay, so these are the terms you have to remember: preterm, very preterm, moderately, and late preterm infant. So what is happening is the fetal lung maturity. Okay, fetal lung maturity is happening when at 34 weeks of gestation, fetal lungs will be completely mature by the term, and 34 weeks से fetal lung maturity start होता है. So this thing you have to keep in mind. Also the fetal lungs में जो surfactant होता है, it starts from 20 weeks of gestation and it will be seen in the amniotic fluid at 28 weeks of gestation. In the amniotic fluid 28 weeks, and it starts producing at 20 weeks. Next we will see the risk factors. So the most important risk factor will be any mother who is having a previous history of preterm labor. So she is the definite most important risk factor of preterm labor, that next pregnancy will definitely be a preterm labor. Okay, if she is having history of preterm labor. What is the most common cause of preterm labor? So most common cause is idiopathic, and it is followed by an infection. So what are all the infections? Okay, also the cause is iatrogenic. Iatrogenic means self-induced. For any reason we are inducing the pregnancy, it may be counted in preterm labor. Okay, if the mother is having premature rupture of the membrane, if the membranes are getting ruptured before the time, that is also a cause of preterm labor. Then any spontaneous unexplained preterm labor with intact membranes. Okay, next is what are the infections? These infections are nothing but it is the associated findings which come with preterm labor. So which are the infection? Most important infection associated with preterm labor is bacterial vaginosis, as you can see in this picture. Okay, this is the cervical opening and this is the infection, this white secretion, this is the infection of bacterial vaginosis. Next is Gardnerella vaginalis, Urea plasma, Urea lyticum, Mycoplasma hominis, and Fusobacterium. So what is the threshold for viability for the child? Threshold for viability means, now in Western countries there is a high facility, okay, high facilities in the NICU, in the labor room. So even they can save 24-week baby also can be saved. But in India we don't have that much facilities. Okay, so here it is considered as 28 weeks. So 28 weeks ka preterm baby can be managed in India. So the range comes between 24 to 28 weeks of the gestation. What are the other causes which is associated with the preterm labor? For example, if the mother is from a low socio-economic status, she is having stress, financial stress, okay, so that stress is going to come on the baby. That because of that, contractions can increase and it may lead to preterm labor. Then smoking, if mother is having a history of smoking. Next is obesity, diabetes, any congenital anomalies like of the uterus, like septate uterus or bicornuate uterus. If there is overstretching of the uterus, it is creating pressure on the uterus. For example, in case of twin pregnancy or increased liquor, that is polyhydramnios, multiple pregnancies, and in case of bleeding. So polyhydramnios will lead to increased uterine distension. Because of that, preterm labor can occur. What are the contributory factors in preterm labor? Contributory factors in preterm labor are extremes of the maternal age. So if the maternal age is teenage, extremely low age means less age for pregnancy, and extremely elderly, okay, so these two are the extremes of the age, so this may be a contributory factor. Extremes of the maternal weight, if there is too little weight gain, and if more weight gain is there, that is obesity, so these two are also the contributory factors. Then short inter-pregnancy interval, that means there is a less interval in the two pregnancies. Bleeding in early pregnancy, if there is a history of any threatened abortion in the previous pregnancy. Then chronic maternal stress, mother is having chronic stress, okay. Then chronic gum infection, so this if mother is having giving complaint of a gum infection which is chronic, so this gum infection may lead to systemic infection, and it will go to the baby, that will lead to preterm labor. So we will see some clinical aspects. So for example, a woman at 30 weeks comes to the emergency with abdominal pain, okay. How do you diagnose a preterm labor? So she is at 30 weeks of pregnancy. So regular uterine contractions will be there associated with cervical changes. So if there is preterm labor, how do you diagnose it? So the mother will tell there is regular uterine contractions, madam, and cervical changes you have to see. So what are the three criteria? So there will be 4 contractions in 20 minutes, okay, 4 contractions in 20 minutes. Then cervical dilatation will be more than 3 centimeters, and the length of the cervix should be less than 2 centimeters. So these are the 3 criteria. If these 3 criteria are meeting, okay, if these 3 criteria are meeting, then you can say that the mother is having preterm labor, okay. Then you are 100% sure that the mother is having preterm labor. Then what if any cervical changes is not seen, okay, any marker is there that we can use, okay. If cervical changes is not there, then one of the 3 criteria is not being fulfilled, then what we will do, we will see for any marker, okay. So what is that important marker is, that is fetal fibronectin. Fetal fibronectin is found where? In the cervico-vaginal secretion. So you can see in this picture, this is the uterus, this is the uterus, okay. So this black part is the uterus, and there is a baby lying inside. This blue membrane is the fetal membrane, and decidua is the black internal membrane of the uterus. Then this red part, okay, which is between the decidua and the fetal membrane, that is the cervical vaginal secretions. So in this you will find fetal fibronectin. So these fetal fibronectin will be secreted into the cervico-vaginal secretions. So it is nothing but a glue between fetal membrane and decidua, okay. So when it is detected between 24 to 34 weeks and can predict a preterm labor. It can predict a preterm labor between 24 to 34 weeks of gestation. So if in case of infection, okay, now it can be, means it can be or it cannot be. So if in case of infection, if the mother is complaining of infection, bleeding or leaking, or if there is any cervical discharge, then this value can be positive or negative. So if in case, if the value is positive, then the predictive value is low. That means if this test is coming positive, then your prediction of preterm labor is very low. But how we can use this instead of it is, if it is negative, if the test is negative, then the predictive value is very high. So for example, a 30 weeks pregnant mother comes with pains with no cervical changes and mild contractions. Okay, you are doing a fetal fibronectin test. Fetal fibronectin test comes negative. So what we have seen, that the predictive value is very high. That means if negative, that means that she is not having preterm labor, and then you can send her home. Okay, so next. So is this clear, all of you? Next is, we will see the cervical length measurement. So cervical length measurement less than 25 mm at 24 weeks is the predictor of preterm birth. Okay, less than 24 at 25 weeks is a predictor of preterm labor. So if the cervical length is 20 mm, what to do? Then you have to do one procedure that is called as the cervical cerclage. What is cervical cerclage? You can see in this picture that this is the placenta, this is the uterus in which baby is lying. Okay, this is the baby, and this is the cervix. Okay, this is the cervical opening. So what we are doing in cervical cerclage is, we are stitching it from here. So if we are stitching it, that means there is no point of the baby coming out. There is no point of the baby coming out, and preterm labor won't happen. Okay, but it is not useful for multiple pregnancies because space won't be there, and also not useful if there is no history of prior preterm labor. So we have seen that the high risk is prior preterm labor. So if mother is not having any history of prior preterm labor, we should not do this. Okay, cervical cerclage. Then what we will see, the management of the preterm labor. So in management of preterm labor, we are having two concerns, that is lung maturity of the fetus and when to stop labor, whether to stop labor or not. Okay, whether to stop labor or not means, how do we stop labor is tocolytics. We will use tocolytics. We have to stop the contractions, that is the use of tocolytics. So lung maturity of the fetus. For lung maturity, we will give steroids for the fetal lung maturity. When to give? We are giving this less than 34 weeks of gestation, because we have seen that fetal lung maturity will occur after 34 weeks of gestation. What is the drug of choice? Drug of choice is dexamethasone and betamethasone. Both are equally efficacious, but we are using dexamethasone more in India because it is cheap and easily available. Okay, what is the dose of dexamethasone? Dose of dexamethasone is very important, 6 mg 12 hourly. Okay, 6 mg 12 hourly for 4 doses. And what is the dose of betamethasone? We have to double the dose, 12 mg in every 24 hours. Then we have to give only 2 doses. Okay, so the total time taken for steroid to cover the complete dose is 48 hours. And the effect starts after 1 dose, after 24 hours of the first dose. Okay, so we are having, like, for the complete course we need 48 hours, but the effect of the drug will start 24 hours after the first dose. Okay, so whether we are stopping labor or not, okay, so we are just giving tocolytics to the mother to buy the time for steroids to act. Okay, if the steroids are acting, okay, so your baby is safe inside the womb. So this time will save and you can transfer the mother to the higher center in that time. Okay, only for that reason we are giving tocolytics, and it is not used after 33 weeks of gestation. So whether when in preterm labor allowed to progress. So when is the preterm labor allowed to progress? So if the mother is in active labor, we will let the labor to progress. If more than 34 weeks, then need not stop because fetal lungs are already mature. And placental abruption, okay, placenta is getting abrupted from the uterus. There is already bleeding occurring, okay, so we will not stop the labor. Fetus is compromised inside, then won't stop the labor. Congenital anomaly, okay, dead fetus, because we need to remove the fetus out. So in case of chorioamnionitis, this is a very dangerous condition because it will lead to maternal sepsis and also fetal sepsis. Then again in case of preeclampsia and eclampsia, we will not stop the labor and we will let to progress it. So we will see something about tocolytics. So what are tocolytics? We have to, when we want to stop the contractions, we use tocolytics. Okay, so most commonly used is nifedipine. It is a calcium channel blocker. It is cheap, orally allowed and most commonly used drug. Beta agonist, ritrodrine, isosuprine, terbutaline. So if these are having some side effect, that is tachycardia, tremor, hyperglycemia and pulmonary edema. That is why we are not using these beta agonists. Then prostaglandin inhibitors, indomethacin. Side effect is oligohydramnios, premature closure of the PDA, okay, ductus arteriosus. That is why we won't give endomethacin also. Magnesium sulfate can also be used, but it has a major side effect on the baby, that is bone thinning can be seen in the fetus. Also we have one drug, that is atosiban. It is associated with fetal morbidity according to the sources and it is not used in India. So oxytocin receptor antagonist, the action of atosiban is oxytocin receptor antagonist. So this is all about preterm labor. I hope you understood this class and we'll meet in the next class. Till then, please subscribe my channel, like and share to your friends. Thank you.